Hello, everybody. Welcome to the first opportunity that Cypress Home Care Solutions has had to interview one of our valued partners for our Caregiver CEU. So we're so glad here to have Cameron Svendson from Palliative Care Alliance. He's the Chief Strategy Officer there, and he has come to let us know what palliative care is, because for those families that are with us, all of the caregivers that I'm sending this out to, all of the people who are joining us today, he has a great service that you qualify for. So we want to tell you more about it. Welcome, Cameron. We're glad that you're here.
Thank you very much, Michelle. I appreciate it.
Absolutely. I want to let anybody online with us know that if they have any questions as we go along, type them in the chat and we will be asking Cameron some questions at the end. But I want to start off. Cameron,
Yes.
what is the current definition of palliative-based care? And it's a community-based care you have now, right?
That's right. Yes.
Okay. Tell us more about this. What is it?
That's what everybody says. What is palliative care? And it's actually changed a lot over the years. So this is probably really good timing, because I think the way that we define palliative care and maybe the way other companies across the country define palliative care might be a little different. But I think it's really important to note that palliative care, from a community-based standpoint, which means when a person isn't in a hospital, but maybe in their own home, in their own residence, when they're receiving palliative care there, it is for the benefit of symptom management for a chronic disease or a serious illness. And they may be going through treatment. And I'm going to give cancer as an example, right? So when people have cancer, they might be going through chemotherapy, maybe radiation, and they're struggling with some of the symptoms. They may be confused about medications they're supposed to be taking or the regimen that they're supposed to be on, and they really need intervention from somebody once they're home. I think a lot of the people that we deal with are often older. They're above the age of 70, and so a lot of times when they go to their doctor's appointments and they come home, they think that they are aware of or remember what the doctor has indicated, what they've said, and they're not. And that's true no matter what age we are. I think we get confused because the doctors rush us through the office.
Well,
So
and they say words that we've never heard before, and medication
right.
names we don't know.
Yes, that's exactly right.
Yeah.
And so knowing that that's the case, knowing that somebody can follow up with you at home and really manage that and explain it again and talk about in way of prognosis, not just, the simple terms, but maybe the future terms too, about what they're going to need. People struggle with diseases all along the stages and the process of the decline during those stages, and they don't just struggle physically with those things. There is some emotional, psychological, even spiritual concerns, and we address all of that that's what palliative care is. It's meant to address those problems as they're occurring.
So, how do you do this? If a person's in their own home, they don't have a nurse who lives with them, they don't have social workers who live with them, and it sounds
Right.
like you're trying to accomplish a lot. So, what does this really look like?
Another great question. So, it looks like there is the distinction, I think, and this is where it might be different across different cities, maybe across the country. So when I do talk about palliative care currently, it's based on our model, the Palliative Care Alliance model, which I believe is probably it encapsulates more of what the traditional palliative care model should be, and that is a multidisciplinary one. So it's not just a doctor visit once a month or a nurse practitioner visit once a month where they're checking in on a patient and prescribing medications, but they're missing maybe some of those emotional and psychological pieces that are a part of a person. And
Mhm.
so when we talk about this model with Palliative Care Alliance, it is a nurse that comes into the home. It is also a social worker and a nurse practitioner. So you get three disciplines that get to visit with a patient on a consistent basis, 4 visits a month, which is more than you'll hear most models of palliative care be able to offer. So when you're seeing somebody once a week, you get what's going on with them. But not only that, I think it's important for everybody to know that it's not just the in-home personal visits face to face, it's also availability telephonically anytime.
Oh, wow.
So 24/7 kind of access to somebody. And in the middle of the night, if there's a problem, if there's a concern, that can be triaged and not just, call us back at 8 to 5. So
Mhm.
that's a big part of the model for somebody at home.
That's amazing to have that kind of ongoing, consistent support.
Yeah.
Now, I happen to already know this answer, and this is why I wanted to have you on today. But, and I'm talking to folks, this sounds really expensive.
Right.
So, can you tell everyone, this is so exciting to me, how is this paid for?
Well, when we started this venture 7 years ago, our goal was not just to provide the services to people in their home. Our goal was to be sure that it got paid for by their insurance. So this is not a Medicare covered benefit. And I say that to people and they're always like, well, then how's it paid for? We don't ever want somebody to come out of pocket to pay for what we do. That's not been the model. It's not been our objective. But at the same time that we were putting this program together, we were also going to different health plans in the Phoenix area and pitching it to them so that they knew that their membership had this benefit attached to the particular health plan that they had. And it takes a while for health plans to come around and see the benefit, not just the bottom line benefit, but the benefit for their patients or their members. And we now currently work with the All-Tex membership. So the population of people in Phoenix and Tucson, actually, who have the long-term care benefit. And that's Banner Long-Term Care and United Health and Mercy Care. So it's a pretty large population of people across Maricopa and Pima counties who have the long-term care piece to their access plan and need follow-up. I mean, that's really important. So that's how it's paid for right now. I would love, Michelle, love for nothing more than to be able to offer this to every person who needed it across the board. But
Well,
until
especially, what you're talking about right now is so important that it's not just the medical care, it's the mental health piece of it.
right,
We know, you and I know how closely linked physical health is to mental
right,
health. And especially right now, when we are in a time of COVID and physical isolation, a lot of folks that I speak with on a regular basis are experiencing higher anxiety and some depression and
right.
just some desperation that comes with this isolation. And for their physical health, there's some real implications for that.
You're absolutely right. And what more do people want than to be at home? They don't want to go into the hospital right now.
Of course,
Y- y-
that's why Cypress is here to help.
Right,
That's
right,
why you're here to help. And this is where this
exactly.
kind of a partnership can
Right,
keep people home. So, can you go into a little bit about, like, so you have the nurse, you have the social worker,
right.
you have the nurse practitioner. And with that, what types of services, what might they be doing for somebody in an average day?
Well, when we go out and we do the original or the initial evaluation of somebody to make sure that they do meet criteria, and we might get referrals from Cypress, we might get them from hospitals, we might get them directly from the health plan itself. And when we go out and meet with them for the first time, we have to explain what palliative care is so that they understand, it's a little different from hospice and it addresses things in maybe a similar way. But if we're looking at it from these multidisciplinary perspectives, we got to find out, is there depression? What is their medication regimen? What's the nutrition status for them? What's their family dynamic like? What are some of the expectations for leaving their house and going to doctor's appointments, and are they necessary? I mean, there's a lot that goes into somebody's overall makeup, medically speaking, clinically speaking. So are is everything that's being ordered absolutely necessary, or can some things be discontinued? So we got to get to know a person, who they are, what their wishes are, who their providers are, their doctors, and be part of that team to smooth the process from one point to the next.
Mhm. Now, is this different than a hospice service would be?
It is. It is. So I think everybody's pretty familiar with hospice. And I also know that palliative care has been kind of thrown in with hospice,
Mm,
and it's said almost simultaneously many times.
right.
The
Which
doctor
is
is
absolutely part of why we want to have you on. This is November is National Hospice Palliative Care
right.
Month. It's
It,
combined in so many
yeah.
instances.
Yeah.
But Palliative Care Alliance, you're focusing on that palliative piece. So
Right.
yeah, how is that separate?
It's almost like a pre-hospice program or a bridge to hospice. And I'm gonna give a quick example if I can. There
Please.
is a patient that we're currently caring for on Palliative Care Alliance who has cancer, and it's pretty advanced. That being said, she hasn't given up everything that like she still wants to go see her oncologist. She still has some additional treatments that she feels is appropriate for comfort that she has every right to do. And while she's going through that, she's going to be on palliative care, and she's going to have access to our nurse and our team, and they're going to come see her, and they're going to make her feel like she's got support. But when her condition gets to a point where there's not a lot of treatment from a doctor's office or a hospital that can be done to really change the outcome, then hospice becomes necessary. So
Mhm.
hospice is a 6 months or less of life benefit. At least that's the way Medicare has deemed it. And because it's a Medicare covered program, they're looking at that timeline or that time frame. Now, doctors don't know if it's going to be 6 months or 3 months or sometimes 1 month. They don't know for sure. But when the patient has finally reached a point where they're like, yeah, I don't want aggressive treatment anymore of any type. I don't want chemotherapy for my cancer, and I don't want dialysis for my renal failure. When those aggressive measures are all used up, then it's time for hospice. But in the meantime, then the palliative care model and the team that incorporates that is a necessary piece to staying home safely.
That is excellent. And I love this. This is such an important benefit for our folks. And so, one of the questions that we have here, somebody's asking, how do they know if their plan has this benefit? You said it's
Right.
all three. Is it automatic with Mercy Care, Banner, and United?
It is automatic. It automatic in that once we get a referral, we do need to check in with those health plans to confirm that it's okay to
Sure.
follow that patient and provide care. But because we only cover those plans or we only provide care through those particular health insurances, there are other ones out there. I mean, think about all the ones out: Cigna, Humana,
Mm,
Aetna, Blue Cross Blue Shield, you name it, right? If somebody's got a PPO or an HMO, I think it really behooves them to reach out to that plan and say, do you have a palliative care benefit in this plan? And if so, who's the contracted provider?
mhm.
And I wish we could provide care for all of those plans, and maybe someday we will. We're just not it for everyone yet, and there might be others.
Yet it'll come.
It's a matter of
It'll come.
time.
And so, another question here is, how do I get signed up then? Do I need to call my case manager?
um, yes, I would say calling the case manager is a good way to start, but I would to make it easier, it's probably just calling you to call
Mhm.
us, or calling us directly if they have the information, because we can probably explain the program to the case manager faster and explain why that particular person is going to need it.
Excellent. And I am going to have all of your contact information, your flyer in this CEU that we send out to our folks. I'm also going to pop it up on the screen here so that people can see this flyer. It is in the newsletter that people are getting along with this. Your contact information is on there. Um, and so I want to encourage folks, if you need to take a screenshot, do what you need to do, download the PDF. That is there as well. Excellent.
Excellent.
anything else that you really want to make sure people know in our 15 minutes here together?
Um, well, I don't. I think it's really important. This is probably the really the most critical piece to this is don't be apprehensive. Don't think that by calling this that there is somehow going to be a loophole and you're going to get hospice instead. I mean, this really is its own separate program. It's palliative care. It's covered. There's no out-of-pocket costs, and it's just an additional level of support to keep somebody at home and out of the hospital and in line with what doctors are asking.
And it's chronic conditions. It's
Yeah,
the
that's
folks that
correct.
we already are serving that
Right.
qualify for the All-Tech services because there is some type of a chronic medical condition, and it doesn't have to be end of life cancer. It
Right.
can be many, many other things.
Well,
Excellent.
and quickly, those other things are dementia, renal failure, heart disease, respiratory illnesses. There are many other things other than just cancer that do qualify somebody.
And we certainly want to provide all the support we can for those families. So,
Yes.
Cameron, I want to thank you so much for being on with us today.
Thank
Can
you.
you quick throw out your number so that if people want to get in touch with you, they know how?
Definitely. My phone number is 623-337-2583. My name is Cameron Svendson.
Excellent. Thanks, Cameron.
All right. Thank you, Michelle. Great to talk to you.
You too.
Bye bye.